Hello, and welcome to the Future Focus Interviews, part of SCCT 2019. My name is Praveen Ranganath. I'm from Dallas, Texas, and I'm sitting with Dr. Michael Blaha, Professor of Cardiology from Johns Hopkins University. We're going to get started with our interview.
Sure.
Dr. Blaha, let's just get right to it.
Yeah.
You're well known in preventive cardiology and cardiovascular imaging. Is coronary calcium the trump of all preventive testing?
Yeah, I think it is. In 2019, it is. We've worked in this field a long time. We had a hard time convincing people for a long time of how powerful calcium scoring is. And at the prevention symposium yesterday, I thought Phil Greenland, who, if you don't believe me, you believe Phil Greenland, right?
Yeah.
Phil Greenland's one of the most important people in cardiovascular epidemiology. And he said, in terms of his 10 predictions for the future in preventive cardiology, he said, nothing will beat calcium scoring, because for the last 20 years he's tried to beat calcium scoring in terms of risk prediction and has not been able to. Phil Greenland has converted from someone who believed in maybe traditional risk factors for the best for risk prediction in the past to now fully embracing calcium scoring, as do the 2018 and 2019 prevention guidelines, right?
Yeah.
So I think, yes, calcium scoring is the single best test for risk stratification in 2019. You still start with traditional risk factor assessment, but then when you need to further risk stratify, the calcium score really is the single test you need at first. That's based on heaps of data from multiple cohorts over time. Some of us might have argued that really we knew this for the last 10 years, but really the literature has evolved to the point where now we've convinced enough people are aware of our data that it's now made it into the guidelines. So now I think not only is it my opinion that the calcium scoring is probably the single strongest test, it's now ingrained in the guidelines.
Speaking of guidelines,
Yeah.
could you tell us about your thoughts on the role of coronary calcium in the new multi-society cholesterol guidelines?
Yeah, so right, this is where calcium scoring has been elevated to a 2A recommendation, right? A 2A recommendation for those people in the borderline to intermediate risk group, that's 5 to 20% ASCVD risk, when you want to further risk stratify the patient, when the risk is uncertain, when the decision to treat is uncertain, or as part of that shared decision-making process that they describe in the guidelines. Yeah, so I'm in support of this. I think the SCCT came out in front on this. In 2017, the SEC decided to put out their own calcium scoring guidelines, and this is what we wrote. We wrote 5 to 20% ASCVD risk would be a great intermediate zone to test patients in the context of shared decision-making. And I think that the ACC-AHA guidelines then used our guidelines is a starting place to write their guidelines. I think that was a good move by the SCCT. I think it was a smart move by the ACC to piggyback on what the thinking and the summary of the data that we already did. So I'm pleased. I'm pleased with what the guidelines say. I can nitpick on a few things. For example, I still think that low-risk patients with strong family histories are a great person to scan. That's not explicitly mentioned in the guidelines. In fact, that patient really isn't recommended for scanning, although many of us do that. But generally speaking, this is a big win for cardiac CT, win for the cardiology community, and really bringing the guidelines up to date with how many people are already practicing, and then hopefully bringing calcium scoring into many practices where they didn't use it before too.
Now, when we mostly discuss about calcium scoring, we talk about a dedicated calcium scoring CT.
Right.
A lot of buzz is being generated about identifying or qualifying coronary calcium on non-cardiac CTs, just general chest CTs.
Yeah.
I wanted to get your thoughts on it.
Absolutely, absolutely. In fact, I just went to a couple sessions where the biggest thing nowadays is not only us looking at those non-gated chest CTs for calcium, but maybe automating that process with AI algorithms, et cetera. So maybe the medical record knows that incidental calcium, and you could query it in the future for, has this patient had a CT scan before that showed calcium? That's the future. But the now is, at least on all of our non-gated chest CTs, there's now a class 1 recommendation from the SCCT and the Society of Thoracic Radiology, they're on board too, to at least provide, as you say, a qualitative calcium score read on all these studies. And that means none, mild, moderate, severe, which for us means maps onto 0, 1 to 100, 100 to 400,
Right.
greater than 400 or 300. So we're all familiar with those categories, and you and me can look at these studies and reliably put someone in one of those categories, even if you can't provide a formal quantitative score on these non-gated studies. So absolutely, this is very important. If I get a referral for a patient with severe incidental calcification, I don't even need a formal calcium score. I know that they're high risk.
Right.
So that happens several times in my practice. I think that clinicians, other clinicians from other fields are becoming more, and radiologists in particular, are becoming more aware of these guidelines, and I'm getting more referrals for incidental calcium. I'm getting more from my fellows to open up the CT scan that they had for a pneumonia evaluation a year ago and look at them and make decisions based on that data that's embedded in the medical record. Of course, the SCCT published the CAC digital reporting system, data and reporting system, which codified kind of how to put these non-gated chest CTs into a rubric that could be, like I said, mapped on top of the traditional Agatston scoring with that familiar kind of mild, moderate, severe, 0, 1 to 100, 1 to 300, and greater than 300. So I think we're making big progress in this area. Tons of people get lung cancer screening CTs. Tons of people get CTs for a variety of reasons. This is free information that we've been ignoring largely. It's not helpful, for example, when, in my opinion, when a radiologist either doesn't mention it or says calcification present. So if they were to use this kind of ordinal scoring system, it would be very useful. And then, gosh, there's just the world is open for then multi-disease screening in the future, or maybe subclinical lung disease, subclinical cardiovascular disease, cancer screening could be all combined together.
So then what are you most excited for in the next steps of cardiovascular imaging and preventive cardiology?
Great question. Lots of things. And I'll tell you some of the things that our group is working on.
Yeah.
I'm very interested in this idea of dual, I don't know if screening is the right word, but prediction of multiple disease outcomes from these scans. Me and Seamus Welton from Johns Hopkins and others are looking at the prediction of cardiovascular disease versus cancer or non-cardiovascular diseases over a lifetime after a scan. For example, if you've got a score that's low at 70 years old, you're much more likely to die of cancer than cardiovascular disease. If you've got a score that's high at a young age, you're much more likely to die of cardiovascular disease than cancer, but we can quantify all these things. Of course, it's very hard to make you live longer if you're not going to die of cardiovascular disease. We can make a lot of headway treating patients aggressively who are more likely to die of cardiovascular disease. So thinking about calcium scoring and predicting multiple outcomes, I think, is very important, and the competing risks that we see in clinical practice. We all know that you get more bang for your buck in certain patients. That's not captured in the guidelines as fully. We hope to bring that out to the forefront. We personally have a new calculator coming out that will calculate one's cardiovascular age after a calcium score. It'll convert the MESA risk score into an age. So patients tend to understand that more, right? Yeah. When you tell them your risk is 5% over 10 years, they don't know how to process that. Yes. But if we said your age is 45 or your arteries, based on your risk factors in your calcium, are 70, that actually makes a bigger impact. So as far as risk communication, I think that can improve after calcium scoring. Many of us think that a new calcium score will come eventually to supplant the Agatston score, incorporating ideas of density and regional distribution of calcium, et cetera. Maybe something that could be even more carefully automated, as we talked about with non-gated chest CTs. So that's, I think, part of the future. Well, of course, we have to talk about CTA, too, because eventually, as radiation comes down, maybe we can do this without as much beta blocker heart rate control in the future. Maybe the need for contrast even goes away in the future. And then you're starting to talk about using CTA, even in primary prevention. The last thing I'll say about CT and primary prevention, and maybe some would even take umbrage with the word primary prevention, because when you have people with advanced calcification or advanced plaque, maybe they're not even primary prevention anymore. There's something in between primary and secondary prevention. So we're really interested in is those folks. And can we start applying the clinical trials that have shown efficacy of drugs in secondary prevention to these patients with advanced subclinical atherosclerosis and maybe yield better outcomes? I'm talking about that new diabetes drugs, Vascepa, PCSK9 inhibitors, low-dose rivaroxaban, whatever it is that you name. None of those things, of course, are indicated in high-risk primary prevention. Yet we know that we need to treat these patients very aggressively, some of which have outcomes that are worse than secondary prevention or as bad as. So this is a really big field that needs to be explored, and I think that Amgen's going to be out in the lead on doing a clinical trial, at least enrolling a subset of patients with advanced subclinical atherosclerosis. So I think this is a market for drug companies. This is a clinically relevant category. Thinking about can we start to show efficacy or project efficacy of using aggressive pharmacotherapy in patients with advanced subclinical atherosclerosis. So I think that's a big part of the future that needs to happen. I think we sort of maybe won a little bit of the battle on the true primary prevention, but we still need to learn a lot about this risk continuum in the area between primary and secondary prevention. And maybe we even need a new lingo there. We encourage the terms advanced subclinical atherosclerosis. Primary prevention can be someone who has no plaque. Primary prevention could be someone who has advanced subclinical atherosclerosis, yet clearly distinct entities.
Awesome. So clearly very exciting stuff coming up. When you were training as a fellow, as a resident, were there things that led you to be more interested in primary or preventative cardiology? or what advice could you give to trainees in general as to how to hone their career in cardiovascular?
Yeah, great question. So I was always interested in preventive cardiology, and that came from my prior training as a master's in public health. I always had a clinical epidemiology background. I always wanted to attack the most common diseases. Some people get more interested in rare disease phenotypes. I was always more interested in common diseases that have social and lifestyle determinants. I just was always interested in this. So as I got interested in the field of prevention, it was a life-changing event for me, I guess, when I was probably a resident, when I got introduced to imaging. I said, gosh, this just makes so much sense. We can detect the disease earlier and intervene just on a conceptual level. Even before I saw the data, this just made so much sense to me. Then, of course, we saw that calcium score performs so well. So that's where I then guided my career along the interface between prevention and imaging, where I still do work today, and we still have lots of work to do. And I guess I benefited greatly from mentorship. Of course, Roger Blumenthal, who won the Agatston Award, was critical for me. And then finding my niche, which was, like I said, being a preventive cardiologist. And that means everything from smoking cessation to blood pressure control to cholesterol. But then bringing in the imaging viewpoint was a phenotype that really wasn't as prevalent at the time. And I benefited a lot from then really developing that area. So my advice to, I guess, our young trainees is to find those kind of neat niche areas where you're combining different areas of inquiry and bringing them together in a new way. Finding mentorship, of course. Really being inspired by your patients, because I'd like to think that a lot of my research directly applies to my clinic or comes from questions that patients have. So really spend time with your patients and say, gosh, we really need to know this, and then pursue that. And then, gosh, come to these meetings, come to the SCCT, where a lot of the new technology in CT is being discussed. This will be the way of the future. And that's my advice. I guess my advice also for someone that wants to be in this field, preventive cardiology, very smart to go and get epidemiology training so you know how to work with large data sets, et cetera. So, but gosh, there's so many more opportunities in this field than ever before with the guidelines, with the prevalence of CT around the world, and patients who've had CT scans for many, many decades now with long-term follow-up. So I think it's a great field to be in. If anyone is curious about the field, they can certainly contact us at Johns Hopkins, where we have a vibrant center. And I'm very, very anxious to hear what the next generation of young researchers is going to come up with, something very interesting, I'm sure.
Great. Dr. Blaha, thank you very much. I really appreciate it.
My pleasure.